Gastrointestinal endoscopy focuses on colorectal cancer screening and upper gastrointestinal prevention. Professor at Rome's Sapienza University. He drives cost-effective endoscopy strategy and guidelines, honored by the Japanese Society of Gastroenterology Endoscopy. His work bridge European and global best practice in digestive health.
Thanks so much. Very happy to be here. Thanks, my friend Abed. Very happy to be here in this moment of the Arabic Society. Of course, the European Society is very happy of this. We were waiting for this moment. So we will do a lot of things together, but let's talk later about it. So after two very exciting talks, one a bit more boring on diagnostic endoscopy, but this is very important because, for instance, here in Saudi, colon cancer is a major cause of morbidity and mortality, and an organized program is under development. So I guess this is very important for Riyadh and for Saudi in general. So the first news come from Germany, from Europe, and this is that we are improving. We don't know whether we are improving because we have a better scope, as we have seen here. Also the enteroscope is improving. Or maybe we are improving because we are better endoscopists, but we are improving. This is really dramatic. In 2008, 60% of the German endoscopists, 60% were not good enough, with an ADR less than 17%. Today, 62% are good endoscopies. So what was the bad endoscopist in a few years became a good endoscopy. So when you develop a screening program, you really want your endoscopists to be good endoscopists. But my curiosity was why did we start in the beginning to talk about quality of colonoscopy? For instance, why not quality of upper endoscopy or ERCP or enteroscopy? So I realized that it was Rex in 2000 to somewhat create the problem. At that time, video endoscopy was just coming, and he realized that the colonoscope is not a perfect instrument. Even today, with the colonoscope, you cannot explore 100% of the colon unless you do retroflexion, as we did with Alberto in the last polyp on the ileocecal valve. So there is a problem in the scope, there is a problem in the endoscopist. So in 1997, Doug Rex did a study that was very peculiar. At that time, the standard of care for colon was not colonoscopy as today. It was the barium enema. Radiologists did a lot of barium enema. So when Rex wanted to show the superiority of colonoscopy, he did not start from polyp, but he started from cancer. So he wanted to blame barium enema, to miss cancer. We endoscopists are better in detecting cancer. And in fact, Rex showed that colonoscopy is very good in detecting cancer, but not all endoscopists were good in detecting cancer. In fact, non-gastroenterologist endoscopists missed 13% of cancer. For instance, here in King's, surgeons are not allowed to do endoscopy. So, it was since 1990. Okay, so there was a problem in endoscopy. This was with cancer, not with polyps. Then the next question was about polyps. So Rex started to spy on the endoscopists in his closer room, and he realized that they were missing a lot of small polyp. And then he did the first tandem study to demonstrate that this was true. And about 1/3 of polyp were missed at that time, 1/3 of polyp are still missed today. Then something unexpected happened. Rex somewhat realized that the difference among endoscopists was in the withdrawal, in how you inspect the proximal side of the fold, in the way you clean. He realized that. But then, and he related with quality. But then something very surprising came. And it was a New England Journal of Medicine from one person who never published anything before and never published anything, or nearly anything, after. This Robert Barclay realized that if you measure the withdrawal time and you put a cutoff at 6 minutes to 2006, you can differentiate endoscopists in very bad endoscopists with an ADR of 11% and very good endoscopists with an ADR of 28%. This is an historical study because even today we are expected to provide the inspection time in our report. And for me, this is still a very strong quality indicator. How many minutes do you spend in doing your withdrawal? And this is because it is a key quality indicator in our guideline. So it is withdrawal, but can we also improve the technology, as Rex was somewhat suggesting in 2000? The most easy way was to improve the advanced imaging because we have a high definition to watch a football game at home because the angle of the lens was wider, etc. So there were several attempts to increase the contrast between normal mucosa and the mucosa and to detect more. In this setting, the most shocking paper was still coming from Rex. We are in 2007. Until that moment, the average ADR was the one of Barclay, about 30%. Then high definition came, and he did a study without comparator. But this study was published on gastroenterology. Why? Because somewhat Rex showed that to have an adenoma is not a disease, it's normal. Because 67% of the patient had at least one adenoma. So Rex showed that with high definition, colonoscopy is totally different colonoscopy. So high definition, without any comparator, without any randomized trial, high definition did of endoscopy a new screening strategy. However, randomized trial came, and this is the meta-analysis that showed that high definition anyway increased the detection of adenoma by 13%. However, we can do better. For instance, Fujifilm launched the LCI mode in order to have more contrast between the hemoglobin and the normal mucosa without using the blue light, and Olympus came up with the TXI. Both of them are similar to white light, but they exploit the neoangiogenesis of this scope. And you may see that both the LCI that came before and the TXI are effective in improving the adenoma. My advice to you is, if you do not have artificial intelligence, you should use TXI or LCI, because there is evidence that this helps. Of course, also chrome endoscopy works. For instance, IBD patients or Lynch syndrome are still treated with chromo. With Alessandro, we had this idea to give a tablet with methylene blue, and now they are available in Europe and probably soon in Middle East. In China, there is a new company that is producing, and this is an idea. Of course, dye-based chrome endoscopy work. Where you have a high-risk patient, you should use a dye-based chrome endoscopy, especially long-standing ulcerative colitis. And this is the recommendation by ESLE. In 2012, something also very important happened, and this was the adoption of a split regimen of bowel preparation. For study randomized patient for adenoma detection rate as the primary endpoint of split dose versus non-split dose, and all of them show a substantial improvement with the split dose. I feel that split dose and high definition really changed our way to do endoscopy, both in diagnostic and in therapeutic. In 2013, there was a very interesting attempt that was to put 3 cameras on the same scope, and this should have allowed to expose more mucosa. However, this was not very good scope. It was mostly based on in Europe and the camera in Israel. The camera was very good, the scope a bit less. There was a lot of enthusiasm at the beginning, but then the idea was somewhat compromised by the subsequent studies, and it didn't go through. On the other hand, what we advise, especially in the UK with Edoardo, is to use the Endo cuff that is very successful in the United States. And the Endo cuff works. The Endo cuff flattens the fold and allow you to detect more polyp. And these are all the randomized trials that support the use of Endo cuff. But the most striking revolution is the artificial intelligence. This is the EndoAid that is the only Japanese software that is available in Europe. All of the others were mostly trained in Europe, and I must admit that this EndoAid really works well. In order to inform the guidelines that are coming in the next month, we explored the impact of artificial intelligence on the benefit, but also on the harm. In terms of benefit, artificial intelligence reduces the risk of human error by 50%. So without artificial intelligence, you miss 1/3 of polyp. With artificial intelligence, you miss 1/6. And this is a very compelling reason to use artificial intelligence. In terms of adenoma detection rate, the evidence is very similar to endocuff, etc., and it is about 24%. If we compare any strategy against the other, artificial intelligence appears to be the most robust way to increase ADR as compared with advanced imaging or endocuff. So at the end, I feel that we succeeded. 20 years ago, the problem was the adenoma detection rate, the miss rate. I feel that today we are substantially improving. However, we are falling maybe on the opposite side. Of course, it's very important to detect big polyp as the one that were shown today and yesterday. But we are also doing a lot of overdiagnosis. We are removing a lot of tiny adenoma, and we are also removing a lot of non-advanced adenoma and non-adenomatous polyp. This comes from the guideline on artificial intelligence. When the hyperplastic polyp are detected by the machine, the endoscopy is cut. And so we have an 18% increase in the removal of hyperplastic polyp, and this is honestly overdiagnosis. We work hard here. You do 10 and 10 of procedure every day. If you use artificial intelligence, you need to do much more surveillance. And at the end, one over the other, in Italy, the waiting list for colonoscopy is now nearly 2 years. So the system is really getting crazy with all of this surveillance. This is why we should be very conservative on surveillance, but it's not easy to explain this to the patient. So when we look at all the way we have to improve the adenoma detection rate, most of them are extremely effective, especially the inspection time, the split bowel prep, the artificial intelligence have been hugely impressive. Most of them were not considered harmful. On the other hand, with artificial intelligence, there is more awareness that overdiagnosis and especially removal of a plastic polyp may be a very stupid cost for the society, but there is also a relevant of cost. Artificial intelligence is extremely expensive, also the new endoscopy tower, so immediate massive implementation of this technology is too expensive. So at least in Europe, we are witnessing a very gradual adoption of artificial intelligence as much as it was for high definition when it came about 10 years ago. I love EndoCap. I don't know why it's not so successful in Europe. While waiting for the Arabic event, please come to the European event where we are very happy to celebrate the extremely high level of Saudi endoscopy. So I'm really looking forward to see a lot of friends in Barcelona. Thanks.
Okay.